Hello everyone. I, Dr. Charu Chadda, Assistant Professor at Banarsi Das Chandiwala Institute of Physiotherapy. On behalf of BCIP, I would like to welcome you all to the Alumni Meet Talk series. We are here to discuss nerve tension testing. Today with us, we have renowned neurophysiotherapist Dr. Neha Kutiala. Let's greet our alumni today. Thank you, Dr. Neha, for joining us. Our guest, Dr. Neha, is presently working at All India Institute of Medical Sciences as Research Officer in Department of Neurology on rehabilitation-based researches. She has presented papers at various national and international platforms. She has won Top 10 Young Investigator Award 2018 at 11th World Stroke Congress, Montreal, Canada. Won Bursaries Award at 24th World Congress of Neurology, Dubai. She has been co-investigator in DST-funded projects. Presently, she is working in NIHR-funded project with University of Central Lancashire, UK. I appreciate on behalf of BCIP the admirable work of her done in the field of neurology and neurophysiotherapy. Now, I would like Dr. Neha to take over the session and enlighten us with nerve tension testing.
Thank you so much, ma'am. Thank you for this introduction. So, hi, ma'am has already introduced me. Now, I'll start with the nerve tension testing, the topic for today. So, I'm sharing my screen with you. And yes. So, yes, we start with today's topic. Today's topic is nerve tension testing. So, one second. Yes. So, key of anything in physiotherapy we practice is anatomy and physiology. Neurodynamic is something we'll be learning today. So anatomy is very I'll be just rushing through all this because I'll be taking the main topic is nerve tension testing. So anatomy, obviously, it's like the brain has two nervous system is two like central nervous system and peripheral nervous system. So basically we'll be dealing with the peripheral nervous system with this. So peripheral nervous system basically deals with your cranial nerves and spinal nerves. We will be dealing only with the spinal nerves when we talk about the nerve tension testing. Obviously, indirectly, somehow, central nervous system is involved. But basically, it's the peripheral nervous system. So, I start with the basic anatomy, which I'll be rushing through. Brachial plexus. So firstly, there are 4 types of plexus. As we all know, it's like the cervical plexus, brachial plexus, lumbar plexus, and sacral plexus. We are talking about the brachial plexus because our arm is basically supplied with the nerves coming from the brachial plexus. So we'll be talking mainly about the median nerve with the root value C5T1, radial nerve C5T1, and ulnar nerve C8T1. We all know the function course of these nerves. So lumbosacral plexus. The other thing I want to say is when there are 4 types of plexus, lumbar and sacral, why we are dealing with lumbosacral plexus? So because the main thing when we are talking about the nerve tension testing is we're talking about the sciatic nerve and femoral nerve. These are the 2 nerves which basically have are most common causes of neuropathy, entrapment neuropathy, and that's why L4, L5, the spinal nerves from the ventral rami, they join to form the lumbosacral trunk, and they further gives these peripheral nerves, that is femoral nerve and sciatic nerve. That's why we basically deal with lumbosacral plexus when it's nerve tension testing. And this is just a go through slide for all the nerve roots and the functions, motor functions, which we usually see whenever, and the motor functions affected whenever there is a problem in these root levels. So neurodynamics. So when we talk about neurodynamics, we actually speak about the mechanics and physiology of a system. So what is mechanics? Mechanics is basically the movement or force which allows the motion anywhere. And physiology, obviously. So we all are aware of the nerve physiology. We know how the nerve is formed, like it's from the axons club together to form the fasciculi, and then they all club together to form a nerve. We know the physiology, that how the functions and the properties of a nerve, that is conductibility, excitability, and refractory period, all these functions. So how the conduction happens, it's saltatory conduction. And basically the nerves, the physiology of the nerves is important, because the nerves, they join us with the external environment with a brain, because we have various receptors, mechanothermoreceptors. So this is how the physiology of nerve works, that is, they are connecting us to the external environment to the brain. So when we talk about mechanics, so what mechanics are we talking about? We are when we know the physiology, how the nerve is like physiologically active. Mechanically, how it is active? It has various movements and motions, like a tension. You know, a particular stretch in a nerve is called tension. Longitudinal sliding, that is, if I stretch my arm, the nerve will be stretching in a longitudinal direction, that is called longitudinal stretching. Transverse stretching, that is, if that is a normal mechanism of a nerve. So if I'm overstretching the nerve will transversely slide and take a short route to avoid overstretching. And compression, obviously it's elastic, so compression is a property of nerve. So what is this neurodynamic? It's a part of mechanics and physiology. So physiology, as I told you, the conductibility, excitability, accommodation, various properties of the nerve. So whenever there is a alteration in basic physiology, there is alteration that is called pathophysiology. And whenever there is alteration in mechanics, the basic mechanics we were talking about, the sliding of the nerve, the compression of the nerve, that is called pathomechanics. So the reason of alteration in both these things, the mechanics and the physiology, is called pathodynamics. And this is what is our concept for the neurodynamics. So the general layout of the system I'll be talking about. So there are three general layout of the system, that is mechanical interface. Mechanical interface is basically defined as the tissue or material that is adjacent to your nervous system. The neural structures we all are aware, and the innervated tissues we all are aware of all these. So neurodynamic assessment. Why neurodynamic assessment is required? It is the same thing. It is required to evaluate the length and mobility of various nervous components. So these are usually performed by therapists, and the main reason these are performed is to check the entrapment in cervical neuropathies and all these neuropathies. So upper limb tension test is the first part of this neurodynamic assessment. Upper limb tension test usually involves the three main nerves: median nerve, ulnar nerve, radial nerve. These tests are also called the brachial plexus test, because all three nerves arise from the brachial plexus. And these tests are also called the LVs, because in 1979, LV was the first person who did this test. So these are also called the LVs tests. I'll further move on. So purpose is clear. Just the nerve compression testing is done. It's a part of a neurodynamic assessment, and a part of your this basic neurological assessment also, to rule out the radiculopathies and to differentiate between the radiculopathy from neuropathy. So these tests are used as this diagnostic test, and plus these tests are also a part of treatment. So indications for these tests: neurodynamic testings are indicated for the patients who has symptoms anywhere in the head, arm, neck, and thoracic spine. The symptoms are not severe and problem is not easily provoked. Neurological symptoms are completely absent. Only a minor part of the condition and the neurological assessment stable, not easily provoked or intermittent. So the problem is stable and not rapidly deteriorating and the pain is not severe. So when I come to contraindications, the thing is performing physical examination is inappropriate for either physical and psychosocial reasons. So here I would like to say one thing. So performing physical examination is inappropriate, and there was a last point in indication the pain is not severe to time of examination, but there is no latency in terms of symptoms provoking, and the problem is stable and not rapidly deteriorating. So what we are supposed to think here is, every time a radiculopathy, which is the patient comes with the complaint of a compression or symptoms similar to that of nerve entrapment or compression, is not always because of the radiculopathy. They can be a neuroplastic radiculopathy. They can be various infections like TB, HIV. Then there are various demyelinating disorders, and we call them a cranioneuropathies. So every time a neuropathy is not coming from a spinal nerves, they are cranioneuropathies also, like your GVS, which is called acute inflammatory neuropathy, polyneuropathy. So we have to be very clear when we are supposed to use this test and when we are not supposed to use this test. If the patient is having the history ki I had a fever and all of a sudden the fever went off, I took medicines and now I'm having all this tingling sensation, or I'm not able to whenever I try to take something with my hand, there is a like I'm not able to move my hand, and at some point I have some tingling sensation. There can be a reason that this is not purely a radiculopathy. This can be a infection because he had a history of fever. So whenever a patient comes to you with indications, you have to be very clear with this concept that you should know when to do this testing, when to not to do this testing. There's no harm asking them MRI reports, all the blood reports, what was the course of medicine done by you, because at times the medicine suppress this all symptoms, and because of suppression of all these symptoms, the patient may not have fever, but the blood reports will clearly tell you if ESR is raised, if other their WBCs are abnormal, and all the other factors are there. You have to look into all this, and then you have to proceed the testing. So indications and contraindications are very important because the symptoms are same, but we have to be clear when to do this test and when not to do this test. So severe pain in the examination could unnecessarily provoke the patient symptom. This is again, if a patient is having some demyelinating polyneuropathy or some other problem, the symptoms may be provoked. So it is a contraindication. There is a heavy bias towards psychosocial issues. Yes. So there is something somatosensory problems we say. So patients usually have the problem with touch pain and all, but every time all these somatosensory problems are not a part of neurodynamic testing. So we have to be clear. The history of a patient has to be clearly taken, and you have to be very attentive whenever you are taking a history of a patient for doing this neurodynamic testing. So we move further. Normal responses. Yes, because neurodynamic testing usually involves the stress and tension which is produced throughout the nerve course. So there are normal responses which we usually expect. That is a deep ache stretch in the cubital fossa whenever we are doing upper limb tension testing. A tingling sensation in the first 3 fingers or thumb, that depends on which nerve we are stretching. So there may be a tingling sensation. Stretch in the anterior shoulder aspect. Cervical and lateral flexion and test side increase the test response, and cervical lateral flexion towards the tested side decrease the test response. So these are the normal test responses which we usually expect. So if a patient, you have to be very clear about when the test is positive and when the test you have to say that this is a normal response. So if there's a tingling sensation in the wrist, that doesn't mean the patient has responded positively for the test. You have to be clear about this. Precautions, yes. So there are few precautions which a physiotherapist should take. That is the nerves in the upper limb are complex but weaker. So do not stretch it beyond a particular limit. And the test involving many joints and muscles, hence it's a complex, so easy to forget structure, can get irritated. So the method which is followed, and it is actually something which you have to follow it, is whenever you start neurodynamic testing, you do not start it on a affected side. Do make sure that first the neurodynamic testing is done on the normal side, and the positioning should be correct. And whatever the pain sensitizers are there, usually the sensor, we started with the shoulder. For the upper limb tension testing, we started with the shoulder, then the forearm, arm, wrist, hands, and usually elbow is the last thing, because we use it as a sensitizer, and cervical spine also we use it as a sensitizer. So what is sensitizers? I'll explain you once I'm using it in the test. So upper limb tension testing, that is ULTTI. This is done for the median nerve. So firstly, the position of the therapist will be facing the patient. Patient should be comfortably lying down on the supine position, and the patient's arm should be resting along with the therapist's thigh, and the therapist's right arm should be holding the left arm of the patient. So patient's forearm and arm should be lying on, resting with the thigh of a therapist is very important, so that therapist both hands are free and they can perform a test. So shoulder, so the first point is, this is something you have to do accordingly. The way, like the first point is shoulder glide, girdle depression, then shoulder abduction, shoulder external rotation, forearm supination, wrist, finger extension, elbow extension, and cervical side flexion. So I'll be showing you a video also, but meanwhile, this is what we are supposed to do. Therapist standing facing the patient. The arm is resting on thigh of the therapist, so that both arms are free to perform the test. So you can go through the picture. That is, the shoulder is abducted to 90 degrees, and then the arm is externally rotated. The shoulder is rotated. Elbow is stretched. Fingers and wrist are stretched. And in the last figure, that is E, this is used as a sensitizer. So if the symptoms are not provoked, we ask the patient to kindly side laterally flex the cervical, the head. Make sure the patient laterally flex, not rotate. So you have to be very careful about these few things. And the abduction in ULTTI is 110. So till 110 degrees, the shoulder has to be abducted. So we come to the upper limb tension testing 2 for the median nerve. This is also for the median nerve. The steps this test follows: shoulder girdle depression, elbow extension, lateral rotation of the whole arm, and wrist, finger, thumb extension. And upper limb tension test 2, which is for radial nerve. So I'm reading it together because they are opposite, like it's easier way to remember. So after depression, elbow extension. In this, we medially rotate the whole arm, and wrist, finger, and thumb is in flex position. So this is your ULTT 2. So you can see in this, the therapist is actually standing behind the patient. Okay, not facing the patient, and the shoulder is usually resting on the anterior superior iliac spine of the patient, of the therapist. So his hands are free, and the hip movement is very important. So that's why the shoulder of the patient should rest on the anterior superior iliac spine of the hip of the therapist, and both hands are free. So shoulder is depressed. externally rotated, and abduction is minimal in this case. In this median nerve testing, it's only 10% of abduction, and then fingers and wrist are extended. And for the radial nerve, as I said, the position of the therapist and the position of the patient will remain same, but the abduction is also 10%. That is same. It is medially rotated, and wrist and fingers are flexed. So, and we move on to the upper limb tension test 3, that is for ulnar nerve. I'll read through all these points. That is, shoulder girdle is depressed, elbow is flexed, shoulder abduction, shoulder external rotation, wrist finger flexion, and shoulder abduction. So there's 2 shoulder abductions taking place in this test. I'll show you why. So in the first figure, the straight stand of the therapist, facing the patient. Again, the arm of the patient rests against therapist's thigh, so that both arms are free to perform the upper limb tension testing. It follows the same thing, that is elbow flexion. Firstly, the abduction, which is just the 10 degrees, elbow flexion, then wrist and external rotation, wrist and fingers extension, and then again abduction. That the therapist is trying to touch the hand of the patient to the ear of the patient. So this is the video. I'll share it with you. So we start the video. 1 second. Just let me know if the video sound is audible or not.
Yeah, it is not audible.
It is not audible. 1 second, ma'am.
Where we progressively apply neural tension to the median nerve
Okay.
to see if it reproduces the patient's symptoms of paresthesia or shooting pain within the arm. And for this test, the physiotherapist is going to stand to the same side of the patient that we are testing, as if we were looking the patient within the face. So classically for this test, the arm is tensioned before the neck component of lateral flexion away from the arm is produced in order to sensitize. However, in practice, when instructing the patient to bring their ear down to their shoulder for lateral flexion, we often find that they rotate their neck instead, which does not sufficiently stress the brachial plexus or the cervical spine nerve roots. Therefore, what we're going to be showing you in this video is to place the patient's cervical spine into the lateral flexed position before sensitizing the arm, so that you know that the neck has been correctly sensitized for the test. So now we're going to go through the procedure for gradually sensitizing the arm. And we start by depressing the shoulder girdle. And we do that by applying a downward pressure like this with our left hand in order to depress the shoulder girdle. Next, we're going to abduct the shoulder joint to 90 degrees. And so we can bring the arm into this position, and then we can rest the patient's elbow on our thigh or hip. And this means that the patient doesn't have to hold their own arm up because we're doing it for them. Next, we're going to supinate the forearm by rotating it into this lateral position like so to achieve supination. Next, we're going to extend the wrist and the fingers backwards like so. And the fifth movement is to laterally rotate the shoulder joint, which you can do by just lifting up your hip. You'll see that when you lift up your hip, as if you're flexing your hip, that you laterally rotate the shoulder. So that's the fifth movement. And the sixth and final movement is to extend the elbow downwards. So we go through this procedure until the patient's symptoms of paresthesia or shooting pain in the arm have been reproduced. So that means if the patient have their symptoms reproduced before the elbow is extended, for example, at the fourth point, perhaps when you extended the wrist and fingers, if their symptoms have been reproduced here, you can stop the test at this point. And now we will ask the patient to bring their neck from a side flex position back into the midline. If this neck movement has reduced the patient's symptoms, we know that the neural tension has a cervical spine component to it, and so the neck will be included as a part of your treatment program. However, if the neck movement has not changed the patient's symptoms, we know that the neural tension has not got a cervical spine component to it, and the tension has been created by structures more distally. So now we're going to look at upper limb tension test 2A with a median nerve bias, where we progressively apply neural tension to the median nerve to see if it reproduces the patient's symptoms of paresthesia or shooting pain in the arm. And for this test, the physiotherapist stands behind the shoulder of the arm being tested, as if we were looking towards the patient's feet. So classically with this test, the arm is sensitized before the neck component of lateral flexion is added to the test. However, what we sometimes find in practice when instructing the patient to bring their ear diagonally down to one shoulder for lateral flexion, they will instead rotate their neck. And this does not sufficiently stress the brachial plexus or the cervical spine nerve roots. Therefore, what we're going to show you on this video is to start the test with the patient's cervical spine in the laterally flexed position before we sensitize the arm, and that way we know that the neck has been correctly sensitized during the test. So let's go through it then. As the therapist, as we said, we're standing behind the patient's shoulder. And the first movement we're going to do is depression of the shoulder girdle. And as the therapist, we're going to do that by pushing our hip forward onto the patient's so that we depress the shoulder girdle. The second movement is to bring the elbow into an extended position like so. And the third movement is to laterally rotate the whole arm, which we can do by rotating at the humerus. The fourth component is thumb extension, finger extension, and wrist extension, which we can do like so. And finally, we're going to bring the patient's arm into a 60-degree abducted position. So we go through this procedure until the patient's symptoms of paresthesia or shooting pain in the arm have been reproduced. At this point, we ask the patient to bring their neck back to the midline. If this neck movement reduces the patient's symptoms, we know that the neural tension has a cervical spine component to it, and so the neck will need to be included within our treatment program. However, if the neck movement does not change the patient's symptoms, we know that the neural tension does not have a cervical spine component, and the tension has been created by structures more distally. Next, we're going to look at upper limb tension test 2B for the radial nerve, where we progressively apply neural tension to the radial nerve to see if it reproduces the patient's symptoms of paresthesia or shooting pain in the arm. As the physiotherapist in this test, we're going to stand behind the shoulder of the arm being tested, as if we were looking down towards the patient's feet. Classically with this test, the arm is tensioned like so, in this position, before the neck component of lateral flexion to the opposite side is introduced. However, in practice, we often find that when we instruct the patient to bring their ear down towards the shoulder for lateral flexion, they instead simply rotate their neck. And this does not sufficiently stress the brachial plexus and the cervical spine nerve roots. Therefore, what we'd like to recommend is that before you sensitize the arm, place the neck in the laterally flexed position like so. And therefore, you know that the neck has been correctly sensitized before you complete the rest of your testing. So now we're going to progressively sensitize the arm for the radial nerve. The first movement we're going to be doing is depression of the shoulder girdle. And we find that the easiest way to do this is to push down with your hip to depress the shoulder girdle, and that's because it allows both of your hands to be free to perform the rest of the testing. So after shoulder girdle depression, the next thing to do is to extend the elbow fully like so. The third sensitizing movement is to medially rotate the whole arm, which you can do by turning at the humerus like so. The fourth sensitizing movement is to flex the fingers, the thumb and the wrist on the side that you're testing like so. And the final movement is to abduct the shoulder to a 60-degree position like so. So we go through this procedure until the patient's symptoms of paresthesia or shooting pain in the arm have been reproduced. So that means if the patient's symptoms have been reproduced before your final sensitization, for example, if before your abduction your patient has reproduced their symptoms, then you don't need to sensitize the arm any further. At this point, we ask the patient to bring their neck from the laterally flexed position back into the midline. And if this neck movement has reduced their symptoms, we know that the neural tension has a cervical spine component to it, and so the neck needs to be included in your treatment plan. However, if the neck movement does not change the patient's symptoms, we know that the neural tension does not have a cervical spine component to it, and instead the tension has been created by structures more distally. So now we're going to look at upper limb tension test 3 for the ulnar nerve, where we progressively apply neural tension to the ulnar nerve to see if it reproduces the patient's symptoms of paresthesia or shooting pain in the arm. And as the physiotherapist for this test, we're going to stand to the side of the patient on the same side that we're testing, as if we're looking the patient in the face. So classically with this test, the arm is tensioned before the neck component of lateral flexion is added, like so. However, in practice, when we often instruct the patient to bring their ear diagonally to their shoulder for lateral flexion, you'll often find that they simply rotate the neck instead, and this doesn't sufficiently stress the brachial plexus or the cervical spine nerve roots. As a result, during this video, we're going to start by placing the neck in lateral flexion ourselves before we sensitize the arm, and that way we know that the neck has been correctly sensitized for the test. So once we've done that, we're going to start our positioning with the patient's shoulder abducted like so. The first sensitizing movement is wrist and finger extension, and the way that we find easiest to do this is to use the back of your fingers to press down against that of the patient's so that you extend the wrist and the fingers like so. The second movement is forearm pronation, where we turn the forearm in this manner like so in order to pronate, and that's where the downward pressure of your fingers makes all the difference, because it's easy to maintain the extension of the wrist and fingers as well as the forearm pronation. The next movement is elbow flexion, where we can position the patient in the flexed position like so. Next is shoulder lateral rotation. And like we did with the upper limb tension test 1, we can simply flex our hip in order to laterally rotate the shoulder like so. Movement number 5 is shoulder girdle depression, which we can do with our free hand like so, before movement 6, which is shoulder abduction, and we can achieve this by further bringing our hip round. So we go through this procedure until the patient's symptoms of paresthesia or shooting pain in the arm have been reproduced. So that means if the patient's symptoms have been reproduced earlier, for example, in this position, once you've laterally rotated the shoulder, then you don't have to go any further in the test. At this point, we ask the patient to bring their neck back towards the midline, and we see if this reduces the patient's symptoms. If it does, we know that the neural tension has a cervical spine component to it, and so the neck will be included in our treatment program. However, if the neck movement has not changed the patient's symptoms, we know that the neural tension does not have a cervical spine component to it, and that the tension has been created by structures more distally.
Hi, so we come back to this thing, upper limb tension testing. Hello, am I audible? Hello.
Yes, Neha, you are audible.
You are audible.
Okay, thank you. So we come back. So there was one thing which in this video they have shown, that the sensitizer of cervical spine, this head, cervical region, they are giving it before, but in Indian practice what we do is we use it as a sensitizer. So we give it at the last because we follow the principle of butlers. So everything is done and the cervical component is added at the end. One second. To talk about is lower limb nerve tension testing, and the about the lower limb nerve tension testing, the most commonly practiced is straight leg raise. Sciatic, this is for sciatic nerve. So sciatic nerve I've already discussed when we were discussing about the lumbosacral plexus. The nerve root value is L2, L4, L5, S1, S2, S3, and it has two components. That is the common peroneal nerve and the tibial nerve. So common peroneal nerve is basically having the nerve root value of L4, L5, S1, S2, S3, and tibial root is L4 to S2. So the normal method of performing straight leg raise is the patient should be on supine couch, the relaxed position, the trunk and hip should be in neutral position. The examiner it places his hand below the Achilles tendon and above the knee tendon. So this is so that we can avoid the unnecessary flexion of the knee, because the knee is supposed to be lifted as the lever. So the protocol of SLR was suggested by the Berg and Troop in 1979. So leg is taken to the predetermined symptom responses or range of movement, and these responses are compared to the SLR of normal leg. So when we are doing lower limb nerve tension testing also, we should have to keep this in mind, that this is also supposed to be practiced in the normal side and then the affected side. So no pillow should be used during the SLR. The pillow should not be used below the head, below the hip, or below the opposite leg, anywhere. the position has to be straight lying on the couch. Straight leg raise for the sciatic nerve. So the sciatic nerve testing can also be performed in the prone lying if the patient has some problem lying supine. So, and this is the patient is asked to come towards the edge of the couch and the leg is flexed, and the testing is done. So the most expected position for the SLR testing and the most optimal position is supine lying, and we try doing it in supine lying only. So sensitizing additions are there because sciatic nerve has two further nerves and it covers, I think, almost all the whole leg. So the sensitizers are ankle dorsiflexion, ankle plantar flexion, and foot inversion. So this is something I learned is like a pie, life of a pie. So PI is plantar flexion should go with inversion, and this is for peroneal nerve, and opposite is tibial nerve. Hip adduction, this is for sciatic nerve. Increasing hip medial rotation, this is for sciatic nerve, and neck flexion is for meninges, sciatic nerve, and spinal cord. But we usually avoid doing neck flexion and straight leg raise. For checking this meninges, spinal cord, and cervical region involved and all, we use slump test, which I'll be discussing further. So this is the SLR. Here in this picture, I just want to show that the range of motion is 30, so which is normal. That is the range of motion. If 30 is there, L4 is involved, and if a patient is able to move the leg till 90
Neha?
degrees. Yes, ma'am.
Neha, sorry to interrupt, but yeah, you are audible, but if you are sharing some screen, it is not, visible to everybody.
Okay. I'll just share it. Is this visible now, ma'am? Is the screen visible now?
Yes, it is visible.
I'm sorry, but hopefully you've not missed anything. So yes, this was the picture I was sharing. So this is a SLR picture, and I was just showing that the range of motion 30 at L4. So basically the compression or neurogenic causes of back pain usually arises between 30 to 90 degree, which is the normal range of motion of hip flexion is 50 to 120, which is recorded, and that depends on between individuals to individuals. That is, an athlete or a gymnast will have it beyond 120 also, and between 90 to 120. Rest others usually have it from 50 to 90 degrees. So if the pain is there in SLR above 90 degrees, this is purely a mechanical pain. There's no neurological involvement. So these are the normal responses which were seen. That is, I just discussed with you, the normal range is between 50 to 120. So Sweetman et al., this SLR was being recognized as a test. This examination was done that time. The workers between 22 to 63 years of age were taken. So the SLR range of 56 was minimum and maximum was 150. And the mean of 83.4 was the range of SLR which was recorded. And he recorded that this definitely differs between hypermobile individuals and the other individuals. So this the best thing which is preferred is whenever a patient comes to you, you practice the SLR or you perform the SLR on the normal side, and then you will perform it on the affected side, so you have an idea about the normal range of the person, because it varies from person to person. So three main areas which experience symptoms are posterior thigh. These are normal responses because you're talking about the sciatic nerve. So whenever a stretch is given, it will be like posterior thigh, posterior knee, and posterior foot. So some postural responses during SLR can be assessed because some patients are asymptomatic. neck can be flexed, and I think I have already discussed the sensitizers with you: adduction, abduction, and foot dorsiflexion and plantar flexion. So mainly SLR is performed for the discogenic problems interfering with biomechanics and the mechanics of nervous system of toes brain, including sympathetic trunk. So slump test, I'll just go through again the points and then I'll show you how it is performed. So hand should be behind the back, thoracic flexion, then extension of one knee, dorsal foot of extended knee, dorsiflex foot of extended knee, and then cervical flexion. So this, I'll read the femoral nerve testing also with you so that I can explain you both together. So patient in femoral nerve testing is also known as prone knee bend testing, and yes, because we're talking about the femoral nerve, we talk about the quadriceps muscles. So patient should be lying in prone position. Affected side, full knee should be flexed, and the flexion of knee should be maintained for 45 seconds. And if full knee flexion cannot be performed, then the hip should be brought into extension and further stretch till the nerve roots L2, L4. Positive test or shooting pain reproduction of patient symptoms. So slump test is, this is what slump test is. The patient is told to sit on a high sitting position. The hands of the patient should be behind his back or behind the hip, but the therapist should be standing on one side, and therapist hand should be on the occiput of the patient, and the forearm should be resting on the neck and the upper spine. And the therapist will assist the because this is the optimal position, the therapist can assist in bending the cervical spine in this position. The patient will be asked to raise the foot and then dorsiflex the foot. This is how the slump test is done. So again, slump test is basically for the complete neural system. So when we are asking, there's no hardcore thing that the cervical spine should be bent first or the leg should be raised, because if sitting in high position, if the patient is told to raise the leg first and then dorsiflex it, this will rule out the lumbar discogenic problem. And if the cervical spine patient is told to flex the cervical region, or the therapist assistant patient in flexing the cervical region, and there is again aggravation of pain, that is a cervical component is also involved. So prone knee testing, you can see this is prone lying position. Again, the hand of the therapist, one is below the knee and one is holding the ankle, and this flexion position should be maintained for 45 seconds. If the patient does not feel any aggravating pain or any symptoms are provoked, then extension of the hip. This is the optimal position, but this test also has a variant, that is side lying. If the patient is not able to lie down prone, then in side lying position, the affected side to be kept on the upper should be upper, and the therapist standing beside the patient will flex the knee and extend the hip. So this will be same as quadriceps stretching position, but almost same as quadriceps stretching position. So one second, I'll start the video with you. So
we're going to be progressively tensioning neural structures within the lumbar spine and the lower limb to see if this recreates our patient's symptoms of paresthesia or shooting pain within the lumbar spine or the lower limb. And the main structures that are affected with this test are the lumbar spine nerve roots, specifically L4, L5, S1 and S2, as well as the sciatic nerve and other peripheral nerves. In this video, we're only going to be showing you how to perform the straight leg raise on one side, so as to not slow your video down. But it's very important in practice that you compare the straight leg raise on the right and the left sides, so that you can differentiate between the result of the affected and the unaffected sides. And we're going to be showing you different sensitizing movements in the lower limb as part of your straight leg raise. And it's critical when you're performing these tests in practice that the patient is relaxed and therefore all the movements are done passively. So, the key component of the straight leg raise is hip flexion whilst maintaining knee extension. And we're going to increase hip flexion until either the end range for hip flexion or the start at which your patient's symptoms of paresthesia or shooting pain have been recreated. So, for example, let's assume that that point within our patient's test is now, which is approximately 50 to 55 degrees of hip flexion. At this point, we can add in ankle dorsiflexion, which you can do by resting the patient's leg on your shoulder and then using your free hand to add in the dorsiflexion. If this movement increases the symptoms of paresthesia or shooting pain that were created a second ago, this will confirm to you that it is neural structures that have recreated your patient's pain. You can use other sensitizing movements to further confirm this, and those sensitizing movements may be hip adduction or hip medial rotation. You can also use cervical spine flexion like so. It can also be that you use other foot positions to bias certain peripheral nerves to inform your test further. So, for example, you can use the acronym SID, PIP, TED to help you remember different foot positions and what nerve that affects. So, for example, SID stands for sural, inversion, dorsiflexion. So, therefore, to tense the sural nerve, when you're doing your foot movement after hip flexion, add in inversion and dorsiflexion. PIP stands for perineal, inversion, plantarflexion. So when you are doing your foot movement, add in inversion and plantarflexion. And finally, TED stands for tibial, eversion and dorsiflexion. So to sensitize the tibial nerve, add in eversion and dorsiflexion as your sensitizing movements. So when completing our slump test, we're going to be progressively tensioning neural structures to see if this reproduces our patient's symptoms of paresthesia or shooting pain in the lumbar spine and the lower limb. And the main structures that are affected with this test are the lumbar spine nerve roots, the sciatic nerve and the dura mater. So as to not slow your video down, we're not going to be showing you the slump test on the right and the left sides of the patient. However, in clinical practice, it's very important that you do this so that you can differentiate between the patient's symptoms on the affected side and the unaffected side. For the slump test, the patient is going to be in a sitting position and the therapist is going to be standing on the same side as the limb being tested. The first aspect to this test is to ask our patient to put their hands behind their back and then bring their thoracic spine and their cervical spine into a flex position, in essence so that you create a slump. From there, the therapist is going to gently place their hand on the back of the patient's head and their elbow on the patient's shoulder to maintain that slumped position. From here, we ask the patient to actively extend their knee to its end range position or to the point at which their neural symptoms of paresthesia or shooting pain have been recreated. You can also further sensitize this test by asking the patient to actively dorsiflex their ankle. Again, we ask them to dorsiflex to the end range position or to the point at which their symptoms of paresthesia or shooting pain have been reproduced. It is important to know at this stage that reproduction of the patient's symptoms that they reported to you previously, critically paresthesia or shooting pain, is considered a positive result in regards to this test. Many people have often thought that the cervical spine component is the most important aspect of this test. But in fact, if you have recreated the symptoms as we discussed, it's considered a positive test. The cervical spine component of things simply tells us whether or not the dura mater is a part of the patient's condition. So from where we are, we ask the patient to maintain their leg position, and then the therapist can reduce the pressure from the patient's head and ask them to extend their cervical spine. At this point, we may ask the patient whether or not this has changed and specifically reduced their symptoms in the leg. If it has, then this tells you that the dura mater is a part of the sensitization of your patient's symptoms. If it doesn't change the symptoms in the leg, then it tells you the dura mater is not a part of the patient's symptoms. So for our pro-knee bend test, we're going to be progressively tensioning neural structures within the lumbar spine and the lower limb to see if this recreates our patient's symptoms of paresthesia or shooting pain within the lumbar spine or the lower limb. And the main structures that are affected with this test are the lumbar spine nerve roots, specifically L2, L3 and L4, as well as the femoral nerve. So as to not slow this video down, we're not going to be showing you how to perform the test on the right and the left sides. However, it's important to note that in practice, you definitely want to be comparing both sides so you can look for any differences between the patient's affected and unaffected limb. So, the two main components that we're going to be doing for this test are knee flexion and hip extension. Let's start with the knee flexion component. So here we are going to passively flex our patient's knee towards its end range position, or to the point at which their symptoms of paresthesia or shooting pain have been reproduced. If this movement doesn't reproduce those symptoms, then we add in the next component of the test, which is hip extension. And for that movement, the handling is important. The therapist is going to place one hand underneath the patient's knee and then place their shoulder on the dorsum of the patient's foot in order to maintain the knee flexion that you've previously created. Next, with our free hand, we place our hand on the top of the patient's bottom in order to block any movement of the lumbar spine, so that when we bring the hip into extension, we can be sure that all the movement is coming from the hip and is not coming from the lumbar spine. And again, when we recreate the hip extension, we're looking to see if this reproduces our patient's symptoms of paresthesia or shooting pain within the lumbar spine or the lower limb. A couple of points to note as a part of the test. The prone knee bend in general can induce lumbar spine pain for any patient because of the fact that you're closing down the lumbar spine into more of an extended position. So if your patient reports pain during the test, just be sure that it is a reproduction of their previously stated symptoms rather than just lumbar spine pain in general. With regards to foot position for this test, it doesn't matter whether the foot is in a plantarflexed, dorsiflexed position because the femoral nerve does not go beyond the knee joint. And therefore, whatever position the foot is in doesn't make any difference towards the femoral nerve during this test. Finally, you can recreate this test with the patient in side lying. And in the side lying position, you can add in a cervical flexion component in order to sensitize the neural structures, and a cervical spine extension position to desensitize the neural structures. So to summarize this video on the lower limb test.
So yes, here we come to an end of this webinar. So reference of this complete presentation was David S. Butler's, which is an anthem, a Bible for neuromobilization. And thank you. So I guess we can have the question session if you have any doubt.
Thank you, Dr. Neha. That was really an exemplary and elaborative explanation. Now I would like to take upon some questions from an audience. One of the questions is, what is the need of nerve tension testing, Dr. Neha?
Ma'am, the need of nerve tension testing is actually basically the entrapment neuropathies and all, and every time any symptom coming is not always from this neural involvement. It can be entrapment anywhere in the course of the nerve. So nerve entrapment tests are nerve tension test is basically done for the entrapment, but also to include and exclude the reason whether they are neural or they are not neural. So that's why we use the sensitizers. So whenever we have used neck as a sensitizer and the symptoms aggravate, that is, yes, cervical component, every spondylitis or disc problem always leading to the neurological or neural symptoms is not possible. And every neural symptom has a diagnosis of cervical spondylosis or any disc problem in the suppose lumbosacral discogenic problem, and the radiation in the leg is always not having a disc problem. So this is just to eliminate the other factors. That entrapment can be anywhere. It can be the DQ variance disease, can be an entrapment in this cubital fossa, in the near the fibular head, anywhere.
And Neha, could you answer one more question? That is, why do we have two tension tests for a median nerve?
Yes, ma'am. The two tension test, actually it's two variants, like we had it for this thing. The prone knee bending, there are two variants. So the first variant is abduction at 110 degrees. So if the patient is not able to abduct, which is a case when we have different shoulder pathologies, abduction is limited. So if it's not possible, then we use the second variant, which is 10 degrees of abduction, which is easy, with shoulder depression and external rotation.
Okay. Another question is, does this nerve tension test have some ill effect on the normal nerves?
Not the ill effect, but yes, that is this is a skill-based test, so definitely this depends on the skill. That's why it's always said that it should be tested on the normal side and before testing on the affected side. Because one example I would like to give is, whenever we are stretching doing upper limb tension test and doing it for the median nerve, there's a chance that anterior introitious nerve, which is also a part of a median nerve only, gets more stretched. So we should know or test it on the normal side of the patient. So if there's a range that a patient cannot get, is not that flexible, we should not try stretching it beyond that. This is there. And the other thing which I would like to share is, I would like, while preparing this PPT, I came across a study which was done, actually a false positive test done on adults, and basically the adults with no symptoms of cervical and lumbar spine. It was a like Scott Davis, and it is a published research. So this research, 83 patients were taken, normal adults were taken, and 73 were found positive. And he concluded that there's a particular range within which the test should be done, and the range should be determined. That is what I'm continuously saying and stressing, that normal side has to be tested before doing it on affected side, because if in normal individuals also, stretching beyond will aggravate the pain and it will obviously affect the nerve. So we aggravate the symptoms which are already present. We don't provoke or produce the symptoms. This is the concept, and you have to follow it. Yes.
Another question is, Dr. Neha, that how is slump test different from SLR?
Ma'am, slump test is basically, we included the whole neural system test. So we have cervical component, we have lumbogenic component. SLR is particularly for the this lumbosacral region. We usually don't do SLR for the cervical region, though we have a component, but it is not the optimal test for the complete neuronal system, that is from cervical to sacral region.
And what is the clinical relevance of nerve tension testing?
Ma'am, these are highly reliable, valid tests, and they are sensitive and specific also. So there are various papers which are published on this. So I have few which maybe I can share later with you so that you can share with the audience. But these are reliable tests, and we can perform it. The only thing is we have to keep in mind is what in every paper they have mentioned it that it has to be done in particular ranges has to be determined and indicated. So we don't provoke the symptoms, we provoke the symptoms, aggravate the symptoms, we don't produce the symptoms. So they are reliable and specific and sensitive.
Okay, and one last question, Neha, that can we perform nerve tension test in case of swelling in the cervical region?
Ma'am, the reason of swelling has to be you know it has to be clear what is the reason of swelling. If the swelling is because of any inflammatory problem, no, we cannot. If the swelling is because of any other neuropathy, cranioneuropathy, because symptoms are always the same, whether it is neuropathies or radiculopathies. So we need to exclude the reason of swelling. And if the swelling is just because, as far as I know, swellings at times they are because of mechanical, yes, we can, and we can go ahead for the reason to find out is there any entrapment or not.
Okay. Last, I would like to ask Dr. Neha, you have been practicing as research officer at AIMS. So how did the learning and skills you acquired in BCIP help you out there?
Ma'am, it has, because the skill is something which is developed over years, but the base is always you know, the base has to be strong. It's the concept which helps you to develop the skill. So obviously my concept comes from BCIP. From you have taught me. So yes.
You have been a brilliant student, Neha.
Thank you so much, ma'am. Thank you so much.
Uh,
And I think when you give me compliment, you compliment yourself before me. It definitely is there.
So we are all proud of you, and I think I'm the lucky one to have a student like you.
Thank you so much, ma'am. So am I.
Chalo. It was such a pleasure having you as an esteemed resource person here. So
Thank you.
on behalf of BCIP, I would like to thank you so much for enlightening us and making us more knowledgeable, Neha. Those who have still not subscribed to our YouTube channel, kindly subscribe today for more informative lectures, study material, and many more things. Our next topic of webinar would be balance and coordination on 27th of June. So register soon. Thank you all the viewers. Thank you so much, Neha.
Thank you, ma'am. Thank you so
Thank you,
much.
Neha. Thank you so much.
Thank you, ma'am. Thank you.